Dilip, you unmute yourself after that.
Yes, sir.
Dilip and US and Lalit, those who will be welcoming, and Rajesh and Deepak Mathur.
हमें क्या म्यूट करना है क्या?
हाँ बिल्कुल बिल्कुल, आप तो अनम्यूट करोगे ही. Right. So first of all, let me start. Good evening and welcome to our family of this PGNAR. And today's speaker is Dr. Dilip Kachhawa. He'll be speaking on non-healing ulcers, whether treatable, not treatable, what he is doing and what is new in that. And welcome, Dr. Dilip, and your own Jodhpuri Safa and bouquet with you.
Thank you, sir. Thank you, sir.
And you are the additional principal, and let our principal, ex-principal, should welcome you. So, Dr. US.
Sir, yes, sir. Good evening, everybody. It is my pleasure to introduce my friend and one of the leading dermatologists in Rajasthan as well as in the India, Dr. Dilip Kachhawa. Dr. Kachhawa is MD Skin and BD, WHO Fellow, and Diploma in STD NEETs from Bangkok. At present, he is Senior Professor and Head of Department of SN Medical College, Jaipur in the Skin Department. And also, he is Additional Principal of Jodhpur Medical. I wish that this additional word is removed from his name, the Jodhpur Medical College. 60 papers in international and national medical journals, and has delivered more than 100 guest lectures at various conferences, seminars, and workshops on vitiligo and dermatosurgery. He has many awards and honors to his credit, including ITMP mentorship by American Society of Dermatosurgery in 2020, Alan Sinha Award by IDB in 2011, WHO Fellow Award 2005, International Pigment Set Conference 2005, Award Rescon USA in 2005, Asian Pigment Set Research Society Award in 2005, Diploma in STD and AIDS from Asian College of Sexual Education, Bangkok, International Society of Dermatology, New York, USA 2004. His main areas of interest are vitiligo surgery, dermatosurgery, and PRP. Today, I welcome him to enlighten us on the treatment of the leg ulcers. Welcome, Dr. Kachhawa.
Sir, thank you for these excellent words. But sir,
Just a moment. I'll be muting everyone, so please unmute those who are.
Sir, can I start now? Deepak sir, Dinesh ji, sir, can I start now?
Yes.
Sir, Oma Shankar sir, thank you for the nice words. But sir, एक भूल गए एक शब्द आपका शागिर्द.
नहीं.
ये वाली चीज बहुत इम्पोर्टेंट है सर, और हमें बहुत प्राउड फील होता है कि हम आप जैसे हमारे सीनियर हैं, और by virtue of all this and all guidance आपकी है, दिनेश सर की है, सभी की सर. And
Lalit, can you present him a virtual felicitation to Dr. Dilip Kachhawa?
Certainly, sir. It is my privilege and pleasure to honor my dear friend Dilip. We were almost, contemporaries in R&T, and we have seen each other uh, growing in dermatology field. And he is an excellent, dermatologist, wonderful human being. And Dilip, it is my pleasure to, felicitate you with this wonderful token of appreciation. Kindly accept the same.
Thank you, sir. Thank you, sir. This is my pleasure to accept from you. Lalit sir was just immediate senior to me at R&D. And sir, we were talking many times about you. Thank you, sir.
Please share your screen.
Right, sir. Right, sir. Right. Right. No, no, no.
It is live going on YouTube also. So please.
Yes, sir.
Right. Right. Make it on full, please.
Yes, sir.
Right.
Today's topic, though it's a very interesting topic, but dermatologists, they don't prefer, because in now is being an era of cosmetic surgery, everybody wants neat and clean case. So I think this is also an important aspect we should never neglect, and we should help these people who come with us with a non-healing ulcer, because ulcer, as you know, and is a breach in a continuity of skin or mucous membrane. There are different parts. Sir, my main topic with fast आऊंगा, because I'll give an introduction to all these.
So listen, all this is now your. You do it whatever in way you like.
There are, as we know, there are different parts of ulcer: the margin, the edge, the floor, base. I think you all people know. This is the pictorial depiction. Where the floor is, where the margin is, the edge, everything is there. And you can see how the tubercular ulcer look like, how the diabetic or trophic ulcer looks like, a healing ulcer, sloping edge, squamous cell carcinoma ulcer, everted margins, rolled out margins in basal cell. So these are different types of ulcer, which by virtue of which on clinical examination only we can find out the more probable diagnosis in these cases. Of course, we have to look for the confirmatory diagnosis by different techniques. One of them is a biopsy also. Induration of ulcer is a very important part, and it's a clinical palpatory sign, which means a specific type of hardness in a diseased tissue. It's obvious in a well-differentiated carcinoma is felt better. In a squamous cell carcinoma, long-standing ulcers because of the underlying fibrosis, and induration at surrounding area signifies the extent of disease. It could be the tubercular. There are different parameters are there, and every part is important. So now coming to the classification of ulcer, the clinical classification is of 4 types: spreading ulcers, healing ulcers, non-healing ulcers, and callus ulcers. And according to duration, acute ulcer is less than 2 weeks and chronic ulcer is more than 2 weeks. And according to pathological diagnosis classification, it's divided into 3 types: specific ulcers, malignant ulcers, and non-specific ulcers. So I will not go details of these ulcers, because I will mainly concentrate on non-healing ulcer. So it may be a chronic ulcer depending on the cause of ulcer. Here the edge will be depending on the cause. Punched out, maybe whatever the cause is, etiological, whatever the cause. The floor contains unhealthy granulation tissue and slough and serosanguinous, maybe purulent or maybe bloody discharge. And regional draining lymph node may be enlarged but not tender. So this is an example of chronic non-healing ulcer. I'll skip all these slides because
there is no hurry and nothing to skip. You please.
right, sir. मैं कर देता हूँ, आप कहोगे जैसा कर देता हूँ. Okay. So, according to pathological classification, a specific ulcer is a tuberculous ulcer, syphilitic ulcer. It's a punched out deep with a washed leather slough in the floor with an indurated base. Specific ulcer also includes the actinomycosis, Melanese ulcer. These are some malignant ulcers. Example: carcinomatous ulcer, rodent ulcer, melanocytic ulcer. And non-specific ulcers, they include traumatic ulcer, and trauma may be mechanical, physical, maybe chemical, anything. Arterial ulcer, venous ulcers, trophic ulcers, infective ulcers, tropical ulcers, and ulcers due to chilblains and frostbite, martolels, hypertensive ulcers. Their list is so long. These are the specific ulcers, Beggin's ulcer, diabetic ulcer. I might have missed few of the examples, but this includes almost all of them. And this is a Wagner's grading or classification of ulcer. This is very important. Grade 0 is pre-ulcerative lesion oblique healed ulcer. Grade 1 is superficial ulcer. Grade 2 is ulcer deeper to subcutaneous tissue, exposing soft tissue or bone. Grade 3 is abscess formation. Underneath may or may not be associated with osteomyelitis. Grade 4 is gangrene of part of tissue. And grade 5 is gangrene of entire region or area. So defining the very important aspect of ulcer is a granulation tissue. It's a proliferation of new capillaries and fibroblasts intermingled with RBCs and WBCs within the thin fibrin cover over it. This is granulation tissue. Unhealthy granulation tissue is, it looks like pale with a purulent discharge. Its floor is covered with a slough. Its edge is inflamed and edematous, and it's spreading. Unhealthy, pale or flat granulation tissue is seen in chronic non-healing of callus ulcers. So, exuberant granulation tissue is a proud flash. It occurs in a sinus or ulcer, wherein a granulation tissue protrudes out of the sinus opening or an ulcer bed, like a proliferating mass. It is commonly associated with a retained foreign body in a sinus cavity, but it is also at the same time seen in ulcers also, not only the sinus, the different ulcers it may be seen. This is how it looks like. You can see on the margin, this is the exuberant margins. Margins are going above the surface. Investigation, we have to investigate these ulcers for the cause of the ulcer. Diabetes is one of the very important cause of ulcer. Different images, X-ray, CT, MRI, PET, CT, depending on the cause you are thinking of. These all are necessary, especially in venous, arterial, or maybe carcinogenous, and other causes also. Arterial studies for the patient with a suspicion of arterial insufficiency, the Doppler is one. Culture and biopsy, of course, very important tool. In a management of ulcer, the cause should be found and it should be treated. Correction of anemias, deficiency like protein and vitamins, the most important, the nutritional part which is neglected in a few persons, that is very important cause in non-healing ulcer. Proper investigation, as I told you right now, transfusion of blood if required, control of pain and infection, rest, very important for the healing of ulcers, especially if they are on the dependent part. And if they are on dependent part, then the immobilization, elevation, and avoidance of repeated trauma is very important. Care of ulcer by debridement, if it is needed. Ulcer cleaning and dressing, it is a regular feature. It should be regular feature. De-sloughing is done either mechanically or chemically. Mechanically, it is done using scissors, excision, or you can do with a manual dermabrasion also. You can do with a electric this dermabrader. You can do with a even scalpel blade also. Hydrogen peroxide is a very important chemical agent which is used for the cleaning of the floor of the ulcer. I think ये सारी चीजें अपन we all people know. Now coming to the causes of chronic non-healing ulcer. So non-healing ulcer is an ulcer which do not heal up to 6 weeks of time. That is chronic non-healing ulcer.
Dilip, it is not only we knowing, it is basically the principle of this meeting is for the postgraduate teaching also. So whatever youngsters they are listening, there should be a message for them, please.
Okay, sir, बिल्कुल वही करा रहा हूँ sir. I'm trying to cover all these areas, है ना? Right. So local causes include the recurrent infections, trauma, presence of foreign body or sequestrum, absence of rest and immobilization, poor blood supply, hypoxia, edema of the parts, loss of sensation, periosteitis or osteomyelitis of underlying bones, fibrosis of surrounding soft tissue, lymphatic disease. These are the basically local cause, and we should try to rule out them in each non-healing ulcer case. And if we are talking to the general specific causes, then we have to find out the anemia, hypoproteinemia, vitamin deficiencies, tuberculosis, leprosy, diabetes mellitus, very important cause of non-healing ulcer. Even the hypertension, uncontrolled hypertension is again a very important cause. Chronic liver or kidney diseases, steroid therapy, locally or systemically, or cytotoxic chemotherapy or radiotherapy, and the malignancy. These are few very important causes of this. And these are the different methods by which we treat these non-healing ulcers. One is the Usol bath. The Usol is a you have to dilute Usol solution in a basin is used wherein the ulcer foot is dipped and kept in place for 20 to 30 minutes. Usol removes the slough and cleans the ulcer bed. Hydrogen peroxide releases the nascent oxygen and helps in removing necrotic material. Povidone iodine is not used for open wounds, it's only for the surface antiseptic. You have to take care of this povidone iodine. It's a vacuum assisted closure therapy. This is nowadays very common in a non-healing ulcer treatment. It is done by creating a negative pressure 20 to 200 millimeters of Hg, continuous or intermittent, over the wound surface. It causes reduced fluid in an interstitial space, reduces edema, increases the cell proliferation and protein matrix synthesis. I'm sorry, there is some problem has occurred. I don't know.
Nothing, don't worry. Just tap on the screen and then do it. Don't worry.
Okay.
Sometimes it happens. Just it doesn't matter. Yes, you can. Now you again start sharing.
Sir, is it that my screen is visible?
Oh, yes, yes, it is visible.
So I was continuing with the vacuum assisted closure therapy.
Suddenly your voice is gone. Can you listen me? Dilip, your internet connection has probably gone. Your photo has been frozen. Your video is frozen. हाँ नहीं, कोई बात नहीं, वापस स्टार्ट हो लो अब। मैं तब तक तुमको जो है सबको there was some sudden network problem at his end. Now he is again restarted and joining back again for a moment. So in the meantime, Dr. Rajesh.
Very good evening, sir.
Uh,
Hello.
what has happened? ठीक है, ठीक है. All right, all right, all right. There was some acute emergency problems, and now he is logged in back again. Dilip, you can unmute yourself. Dilip, you have to unmute and present your.
I'm really sorry for this unseen problem which occurred.
Don't worry, don't worry. This all happens in this era.
Just speaking you, sir. Just speaking you.
No issue. इसके आपको खाली एक बार जोधपुर में बुला के सबको जो जितने हमारे ये आज हैं इन सबको पार्टी देनी पड़ेगी एक.
सर पार्टी में तो हमें कहीं दिक्कत ही नहीं है सर.
No issue, no issue.
Sir, my screen is visible now.
Yes.
So I'll talk mainly of, sir, the most important aspect of today's talk, because everything is there and there's nothing much about PRFM as well as Jodhpur technique.
No, everything is there, because listen, you need not to understand that you do whatever your presentation is there.
Okay, so here I am really sorry. Once again, welcome you all. Vacuum assisted closer. So this where we were doing.
आपने दो उससे ज्वाइन किया है क्या? उसमें वो आ रहा है, इको आ रहा है.
नहीं, अब तो नहीं आ रहा ना सर.
हाँ, अब नहीं आ रहा. उसको अगर दूसरे से किया है तो उसको बंद कर दो आप.
हाँ सर, कर दिया हमने, कर दिया सर. So vacuum is given to this ulcer and the tube is connected to system suction system. Suction is maintained initially continuously and later intermittently. Redressing is done only after 4 to 7 days. There are also therapies which are being used as an infrared therapy, shortwave therapy, or ultraviolet therapies to decrease the ulcer size is often used, but their benefits still doubtful. This is how this vacuum assisted closure of ulcer is. It looks like the tube connected to the ulcer and then the one end is connected to the vacuum. Maggot debridement therapy is a very popular therapy, but it's to some extent somebody are doing. Though I also tried a few maggots therapy because here in Jodhpur the Ayurveda University is there and they come up with a few maggots. But there are so many flaws in the maggots because you have to keep the maggots separate for the separate person, so it's not possible. And there are so many issues, HIV transmission of some diseases, also viral diseases most commonly. So I abandoned, though I tried in one case, it gives good results, no doubt. There is surgical techniques. The surgical is split thickness SCGs. These are autologous dermal grafts that consist of epidermis and a part of a dermis, and split thickness skin grafts can tolerate a less than ideal wound bed, and they can be used to cover a wider area, and additionally the morbidity of donor site is very low. They are very frequently used by plastic surgeons and surgeons themselves. Full thickness graft, again they are very popular by these plastic surgeons and surgeons. These contains epidermis and entire dermis. So because of these full thickness skin grafts, they are thicker, they are more durable and provides better cosmetic result. But sometimes there are flaws of every treatment. Tissue flap reconstruction refers to movement of a tissue with its intact blood supply from a donor site to recipient site in order to cover a defect. This is again, though our dermatologists they started using, and Saurabh is Dr. Saurabh from AIMS is a very good surgeon for this tissue flap reconstruction. I've seen his cases. He's a very good flap construction surgeon, and dermatologists are also picking up this. And the revascularization of wound can be accompanied by endovascular technique or open vascular reconstruction or both. So now coming to the main, the area which I explored a lot in is a PRFM in non-healing ulcers. This is basically, as you know, what is a PRF? It's a cellular therapy for treatment of non-healing ulcer. Is a major breakthrough in the arena of vascular therapies. The use of patients' own body cells for ulcer treatment relies upon the components present in a blood and platelets concentrate, which contains various cytokinins and growth factors. Cellular therapies such as PRP has gathered a considerable attention recently in the last decade only. The autologous PRF-FM is an advanced generation of PRP which relies on formation of fibrin matrix that is responsible for sustained release of growth factors, mimicking the natural wound healing process. Autologous PRFM use is currently gaining momentum in various fields with the use of facial rejuvenation, non-healing ulcer, and use as a biofiller as well. This is a very good, very cheap biofiller. The procedure which I had done is in a 25 patients. This is basically a study which I had done, and the primary infection in any was taken care using antibiotics and surgical debridement where necessary before starting the treatment. Under strict aseptic precautions, 10 ml of venous blood is drawn and added to sterile centrifugation tube devoid of anticoagulant. This is important. You are not supposed to add an anticoagulant in this for the making of PRFM. Just a simple test tube is enough, without any coating or without any adding anticoagulant. Centrifugation was done at 3000 rpm for 10 minutes. Just simply, you just draw the blood, pour in a test tube, and then go for centrifugation at 3000 rpm for 10 minutes. And here you will see the 3 layers were obtained. The upper straw colored platelet poor plasma, then the lower fraction, and the middle one. And now if you wait for a few seconds, then this whole will be into two parts. One is the RBCs and second is a clot-like fibrin material will be, clot-like membrane will be seen, jelly-like. It will be looking like a jelly. Now I'll show you how it is being done. This is how we are taking the venous blood. This is adding in a test tube. This is a video for, this is excellent video, and everything will be explained in this only. So this is how drawing of blood is, venous blood. You can take depending upon the size of the ulcer. You can go for the 5 ml, maybe the 10 ml if the size is less than 1 inch. I think this 5 ml is enough. And if size is more than bigger than 1 inch to 3 inch, then 10 ml, and beyond the 3 inch you have to go for even 25. So this is by taking all aseptic precaution, I withdraw this blood and now pouring in this container. This container, the side wall of the container doesn't have any anticoagulant, as well as no anticoagulant has been put in this this tube. Now you close the lid. Now go for 3000 rpm for 10 minutes. And when you withdraw this, this will be looking like this, and just with the help of forceps, you take out this jelly-like thing. This is our PRF. It's very simple. And you just press it, it will spread, it will be, you can make it as thin as possible, but around 2 mm thickness is good enough for the covering of ulcers. This is how I'm putting this on a, now this ulcer has almost healed. This was so big ulcer, but now only this part is remaining, and just taking this PRFM and keeping it over the ulcer, and now you can dress with a jello net, and this is jello net and Bactigrass jello net, maybe anything, and then you dress it and bandage it. Leave it for 7 days. This is how, this is very simple procedure. And this procedure is repeated every week up to the maximum, maybe 5 sitting, maybe sometimes you, if the ulcer is large, you can go till the ulcer completely heals, and you will see the healing sign in from the beginning of this PRFM treatment. So this is this you can, I have done to a very large ulcer to 10-15 sittings, and that ulcer was covering the whole buttock. But you can imagine that big size of ulcer. So that is up to basically depending upon the size of ulcer. This is how we have to calculate the wound area using the formula length versus width, and this is quotient there. And this is how the 0 week, 2 week, 4, 6, up to 12 weeks, even you can go for this and see the p-value of this. This is very important in this. I'll not go to details of this study, but you can see the results. Here are the results. So at 12 weeks, you can see this almost good healing of the ulcer. Again, a venous ulcer, and you can see this beautiful healing at 12 weeks. This is again one of the insect bite ulcers I remember so far. And it's again at 12 weeks you can see. At this I was talking of huge ulcer. You can see this ulcer. And in 10 settings it was reduced to this. And though now patient is not coming to us and he is completely okay, and you will be very pleased to listen that this ulcer was of 2 years duration. And if you go to this, you can see this. There is some different levels of ulcer. This is a very deep kind of ulcer, and even this healed. This is very important. You can see the edge. This is separating the ulcer, and this is a muscle here, just below it. And there was a gap between muscle and skin. Even that healed. This is very important. And this gives very good result. And any etiology of ulcer, it heals. This is the beauty of this PRFM. So the autologous PRFM is a very simple, effective way of treatment of non-healing ulcer, and at the same time is not associated with any side effect. The problem with non-healing ulcer is these are the different studies which I had published about this. Now coming to the new extension, new arm for the Jodhpur technique, which was initially popularized for the vitiligo surgery. Now I had started this in non-healing ulcers as well. Autologous, non-cultured, non-trypsinized keratinocyte and melanocyte grafting, also known as Jodhpur technique, is a novel method of epidermal grafting. Previously, it's demonstrated that Jodhpur technique is an inexpensive, simple, convenient approach to attain repigmentation of vitiligo patches, and now this is being explored for this. So as we are doing in vitiligo cases, the similar way, this is similar, the recipient here is not the vitiligo but the non-healing ulcer. So the donor, here again we are supposed to prepare the recipient area first and then the donor area, and the paste from the donor area obtained from Jodhpur technique contains various growth factors. This concept was used for inducing healing in chronic non-healing ulcer over lag. Basically it was an initial case, then a complete study was done and it was published also. I'll show you later on. I'll directly go to the video, which is very obvious and you will understand every step of it. So this is the recipient area. Here we are just denuding the area with the help of scalpel blade. You can use a scalpel blade, you can use the manual dermabrasion. Just because the crusting is so much there in these cases, even with such a good granulation tissue over the floor, but still the crust keep on coming every time. So we have to remove that crust. So this is a donor area. So I prepared the recipient area first, and now coming to the donor area. Here a ring block is given of 2% lignocaine, and then an ointment is applied, and now start dermabrasion. So this is the electric dermabrader, and you can see I am just removing this, and you can see the flake, the paste-like flake, which is being collected nearby it, and I am just taking with the help of spatula. You can see on a spatula also. We have to collect this to cover the entire ulcer. This is very important. So this is how. Again, can you see on this on the donor side? These are the particles.
Clearly visible. It's visible.
These are the particles. We are supposed to take them as a donor material. So now transferring this donor material from a spatula to the glass slide, because basically it's a now crumpled up. So I have to make it diluted, homogeneous, so that it spreads easily over the the ulcer site. Even in a vitiligo case, we make it dilute it, make it a more homogeneous. You can use normal saline or methyl cellulose. Now, once it becomes homogenized, then you transfer to the recipient site. That is the floor of non-healing ulcer. So I'm just transferring this on the floor. And this was a gravitational ulcer. It was a long-standing ulcer in this old man of 70 years. He was also some doctor, not of some doctor so-called. And now I am covering this with the help of collagen dressing. So this is collagen dressing, dry collagen. I covered the Jodhpur technique graft with a dry collagen so that it doesn't come out. Your graft, whatever you have kept in the recipient area, will not come out after keeping that collagen, and then bactigras, and then closing the dressing with a, you can do with a Dynaplast or maybe cotton bandage. And this is site where I am showing you how the donor area is being dressed and left for the 7 to 10 days. And this ulcer site we are supposed to leave for 7 to 10 days. The results were excellent in these cases. The beauty of this Jodhpur technique, I'll show you, I will tell you later on. The volume decreased, everything decreased, ulcer healed 100% by the, even earlier than the PRFM. And these are the few pictures. Even the leprosy wound, this has healed by Jodhpur technique. And so it's a really wonderful, and basically this have an advantage over the non-healing ulcer. The PRFM is that you are supposed to do it at single time surgery. So once patient is coming, you do it, and then patient is coming regularly, then it's okay. Otherwise, you just ask after 2 weeks that you dress your wound at your home, and you will have this granulation tissue and healing of the ulcer in this 6 weeks or 10 weeks or like that. So in conclusion, Jodhpur technique is a simple method of epidermal grafting wherein a small donor area can be used for larger ulcer size with easily learning curve and doesn't have the same time required expensive center. Hence our technique offers the ease, pace and negligible complication, and at the same time rapid ulcer healing. So these are some publications of my technique. Thank you.
Thank you very much. Thanks a lot, Dilip. It was indeed a real experiential sharing. And are there anything in Dr. Rajesh? Can you please see?
I've been just through the chat box. There are no queries. I think everybody was mesmerized what Dr. Dilip sir was telling. Excellent talk with the very minimal infrastructure required, because every now and then we are in habit of just talking of infrastructure constraints and working in government setups and whatnot. But what Dr. Dilip has just shown to us, when there is a will, there is always a way. So with these administrative responsibilities around, since he had been superintendent and now additional principal, he could just squeeze some time for these very novel things and very easy to be done thing. But I think dermatosurgery may be something hesitant for the newcomers, even the old timers also. I'll request Dr. Dilip to organize workshops. For he had been doing it in past for PRP and vitiligo surgery also, and now we can just start doing. And corona graph is just coming down. Hopefully, God forbid, there is nothing like third wave. And definitely, I'll request on behalf of this platform that he may start once again organizing the workshops for youngsters at least to know, and for the seniors who just want to have the finer tips from Dr. Dilip, and would be a real pleasure to work with himself.
Definitely. Thank you, sir. I will try to organize. Definitely.
Well, Dilip, you were talking about the dry collagen, because I normally I use dry collagen directly sprinkled over the wound. So
Yeah.
do you sprinkle it or do it in some other way?
Sir, basically here the collagen is to occlude what we have done.
True,
So
true.
it should not come out from the area where we had applied. So if you are putting a powder, then it will not.
I'm very fond of using aloe vera gel. So I
Correct.
mix it up with the aloe vera gel. And earlier, when there was nothing else, the aloe vera used to do a lot wonders in healing of the wounds. But nowadays, since I also do this PR, I was not doing PRFM. I use PRP and this injecting PRP in the non-healing ulcer, and then putting up the aloe vera gel along with the dry collagen and some
Correct.
antibiotic, and keep it for 7 days. Probably very good result. But I'm impressed with this your PRFM, and I have not used very much PRFM, but I'll try for that. That was something new, good learning today for me. Dr. Arun Joshi, would you like to speak anything about this thing? I can see many.
Sir, we can just unmute everybody,
Dr. Arun
and
is
if any
muted,
questions
sir. Yes.
directly, they can have chat.
All right, all right. What I'll do, just a moment,
Yeah.
just a moment. Now anybody can unmute. Sorry, it was my mistake. I muted everyone. So now you can unmute,
Yes, sir. Thank you,
please.
sir. Dr. Dilip, I would just like to say the greatness and the beauty of your technique is in the simplicity. And as Dr. Rajesh also
Thank you,
mentioned,
sir.
like it can be done, I think, anywhere in all kind of setup.
Yes.
So that is a great thing about it, and quite innovative. And as you mentioned, neglected area. And I may like to say that you may think I am working in Kuwait, so everything is all developed and all. We have a setup, private setup and government setup. Private is dealing mostly with cosmetics, and government setup has uh, two-thirds of the population is expats and working class. So a lot of labor and laborers and the venous ulcer, diabetic. Diabetes is very common. So in my clinic, there is a special diabetic foot clinic. I will start visiting them there and see what they are doing, and I'll start suggesting to them. So that
Thank
will
you.
be,
Thank you. Thank
yeah,
you, Dr. Arun.
really good.
Dr. Mishri Lal ji Khatri, I can see. Dr. ML Khatri, I can see. Dr. Khatri Sahib is a very senior
सर
dermatologist.
उनको भी उनको म्यूट तो नहीं है सर.
No, they have to unmute. Listen,
Okay, okay.
everybody was muted. Otherwise, we couldn't have enjoyed the lecture. But now anybody can unmute. They have to
खत्री
unmute.
साहब पैग लगा रहे होंगे सर.
सर वो रिकॉर्डिंग बंद हो गई ना, दिलीप जी रिकॉर्डिंग चल रही है सर.
एक मिनट now. All right.
बंद कर दो सर.